Well, good morning. Sorry about that delay. Thank you for joining us for today's press conference. If you need access to record or would like to ask a question, please indicate so in the chat. We will limit questions to one question per outlet today, and we are limited to 1 hour. If there are remaining questions in the queue when we conclude and you feel your question hasn't already been answered,
recording in progress.
Please submit your questions in the chat or by email, and we will work to get you a response in writing. We will begin in just a few moments after we grant recording permissions. I believe all permissions for recording have been granted. If you requested permissions in the chat, you should now be able to record. If you still need permissions granted, please leave us another message in the chat. Dr. Vanderhoff, we will now hand it over to you to begin today's press conference.
Well, good morning, and thank you for joining us again today. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health. Well, as the days and weeks pass, it becomes increasingly clear that not only are we leaving the Omicron surge behind us, but we're entering a new phase of our experience with COVID-19. Case numbers and community transmission have continued to drop steadily, as have hospitalizations. Indeed, all but 10 of our counties now have low or medium community levels, according to the CDC. The 10 counties still at high levels include Ottawa to the north and 9 counties to the south, generally along the Ohio River. At one point in January, Ohio had more than 2,200 cases per 100,000 residents. Now our state average stands at 78. That's the lowest level we've seen since August. Similarly, while just 2 months ago, our hospitalizations were topping 6,000 people, today, fewer than 800 are hospitalized with the virus. Now, many communities, schools, and businesses have responded to these changes by relaxing masking and social distancing and other restrictions. Maybe you've allowed yourself a sigh of relief, and understandably so. The situation is improving, and our experience with COVID-19 is evolving from that of a pandemic to more of an endemic state. Reflecting these new realities, beginning on Monday, the state of Ohio will shift its reporting of COVID-19 data from a daily to a weekly cadence. In fact, Ohio has been one of only a handful of states still reporting COVID-19 data daily. Cases, hospitalizations, ICU admissions, vaccinations, which are all currently reported daily, along with deaths, which are reported twice weekly, will be reported each Thursday on our dashboard at coronavirus.ohio.gov. Likewise, data from our long-term care facilities and our partner agencies will also move to weekly postings. Now, all the same information will still be found on our dashboards. The only change will be the frequency of our updates. Now, even with this change, our state team will continue to monitor the trajectory of COVID-19 very closely. We'll continue to update our data, and we will continue to have close surveillance to help us monitor COVID-19 activity and to identify pockets of higher spread so we can work with local communities on timely responses as needed. Now, one reason for this shift is to better align Ohio with the new benchmarks established by the Centers for Disease Control and Prevention. Indeed, as you may recall, CDC's COVID-19 community levels, which were announced February 25th, moved away from relying on these daily case numbers as the sole measure of risk. Now, instead, the CDC is focusing on the severity of illness in a community, as reflected by the percentage of hospital capacity that's devoted to caring for COVID-19 patients, as well as the number of new COVID patients admitted to hospitals over the past week. In this model, new case counts averaged over the past week represent one prong in a three-pronged approach to risk assessment. Now, what's helpful about this new model is that it paints a combined picture of both the rate of spread and the severity of illness. That kind of picture is particularly important for an endemic respiratory illness that tends to ebb and flow, like COVID-19, or even influenza or the common cold. For example, we worry a lot about a wave of the flu that's landing many people in the hospital, even if a cold virus is circulating at the same time, infecting more people, but causing no hospitalizations. Thus, our COVID-19 community level allows us to judge the overall impact of COVID in any given county. Now, looking at the community levels in Ohio this week, 61 of our counties are at low risk, 17 are at medium risk, and as I noted earlier, 10 are at high risk. Knowing the COVID-19 community level in your area can help your community and you as an individual identify prudent prevention measures in light of your own personal health situation. Based on our most recent community levels, the recommendations for masking have changed a good bit, and in fact have decreased for much of our population. In counties with high risk, the CDC still recommends masking indoors in public, regardless of our vaccination status. And no matter what the community level of transmission, we need to remember that there are many people among us who are at increased risk, such as those of advanced age or even the immunocompromised. And they may still want to consider wearing a high-grade protective mask, such as an N95, when they go to a public indoor setting. Now, rapid tests are more available than ever, including for free in many libraries and community centers. So don't hesitate to get a test if you think you might have symptoms of COVID-19. And if you're in a high-risk category and you test positive for COVID-19, consider talking to your doctor or healthcare provider about whether one of the currently available COVID-19 treatments might also be a good fit. The state's supply of these therapeutics, including the oral drug Paxlovid, is still somewhat limited, but we have adequate supply for those in vulnerable populations. Thankfully, we do expect the supply of these COVID-19 therapies to continue to improve, and we hope that the drugs will become an ever more important tool in our COVID-19 toolbox as we move forward. Now, of course, getting vaccinated and staying up to date with vaccination continues to be the safest and most predictable defense that we have against this virus. To date, more than 7 million Ohioans have started their vaccine series, and that's very good news. But that also means there's an opportunity for many eligible Ohioans to potentially benefit from the protection of vaccination. Now, of course, keeping our vaccination series up to date means a booster dose for many of us. And a growing body of evidence suggests that a third dose does indeed provide a powerful boost to our immune system's B and T cells. And it's these important cells in our immune system that really are the foundation of robust protection from serious illness from COVID-19. And it appears that these cells, fortunately, have memory that can last for many months or possibly even for years. Now, joining us today to talk about many of these topics is Dr. Frederick Berkley. He's the president and CEO of COSI. Dr. Berkley has a PhD in immunology and has worked internationally in preventive medicine and on vaccine research at Harvard Medical School. Dr. Berkley, thank you, first of all, for joining us here today. We really appreciate your time.
Dr. Vanderhoff, thank you so much for having me. It's a pleasure to be on with you today.
Well, in your experience talking to people in the community, why are some people still hesitant about getting vaccinated? And what do you think we might do to reach more people and give them comfort with getting the shot?
So that's a great question, Dr. Vanderhoff. And there's so many important pieces to that answer. The first thing, I'll answer the last part first, which was what can we do as medical practitioners, as scientists, people who have some level of expertise in that space, is first of all, we have to meet everybody where they are. You cannot make anybody feel bad, feel ashamed, feel like, pardon the expression, but feel like they're idiots for asking the question. Every question is a fair question, and we need to respond and treat every question with the utmost respect. That's the first thing. And we need to do that for several reasons. One is because people have legitimate questions, but two, this is a legitimate question that doesn't have to do with, oh, is my grass going to grow next week or not? Oh, is my bicycle going to be in the garage or did I leave it at the back of the house? This is a question about people's health and wellness. And so we have to respect where they are with their thoughts, whatever they think they know, whatever they heard, we have to respect that. And then secondly, once individuals who have apprehension about any medical thing, in this case vaccines, but they see that we as experts are really respecting and listening, then they're listening back. And the most important thing, you know this as an MD, the most important thing is both sides of communication need to be open. I can't be blocked as a scientist and think I know everything. Someone who's not a scientist can't be blocked to think, oh, they're a scientist, they're just going to talk down to me. We need to be open. So I wanted to really begin for all of your listeners. You've been doing a tremendous job over the last several months, showcasing the importance of bringing information to the front and sharing it with the community. And that's fantastic. And the rest of our colleagues need to continue to do that kind of stuff. So that's the first thing. Now let's talk about what the actual issues are with folks who have apprehension to taking the vaccine. If you look at population as a whole, there's a very, very small sliver of folks, anywhere from 3 to 5%. So for the audience, remember the times before this pandemic, remember the times before coronavirus, remember the times before even SARS or other things. And we talked about vaccines. Most of us had no problems with vaccines, right? I mean, everybody listening, I'm pretty sure, has received the measles vaccine, the mumps vaccine, the rubella, you've had a tetanus shot. We've had no problems with vaccines for decades. Now, there is a sliver of percentage, maybe 3 to 5% that are true vaccine deniers. Those exist, Dr. Vanderhoff, and that's just hey, the world's a beautiful place, 7.8 billion people on the planet. Some people have an opinion. But the majority of the rest of the folks that have vaccine hesitancy, they're not opposed to taking vaccines. And again, I challenge the audience, you've all been vaccinated for measles, mumps, rubella. I know this, and you've not complained about it. And so why is there hesitancy for this one? And that gets back to all of the things we talked about. Never in our lives, with the exception of HIV, never in our lives have we been in a place where we had a massive pandemic while we're trying to develop a vaccine. So having that at the same time make things kind of interesting. I guarantee you, Dr. Vanderhoff, 50 years from now, 100 years from now, people aren't going to hesitate at all to take the coronavirus vaccine. The pandemic will be over, and so this is another important tool in our toolkit to keep us safe and healthy from things like you said earlier that might be endemic in our communities. But right now, or for the last 2 years, I guess, or I should actually more clearly say 2 years ago to a year ago, there was a lot of feeling of, well, this is new. This is a new vaccine while we're doing a pandemic. And yes, I don't want to be in a pandemic. I'm a regular person. I want to get back to my life. But you know what? I don't know enough about the science, and it's too new. So a few things I'll say to that. One, it's important to understand that as a society, we love new technology. If you don't think that's true, how many of y'all have the original iPhone or iPhone 1, 2, 3, or 4? We don't. We have the iPhone 10, 12, or 13. So, or how many of you are driving a 30-year-old car? No, we try to get a newer car every year. So as a society, we're generally comfortable with new technologies. In fact, we want the newest stuff that comes on. In the case of the vaccine, some of the conversations are, well, it's a vaccine, and I need to make sure that that's been sufficiently tested. The first thing we need to understand and appreciate is every single thing that's called a vaccine that has been approved as a vaccine has been tested sufficiently. The men and women who are making the decision to make a vaccine available, and I want to stress this important point, the coronavirus vaccines that we have right now, the group to sign off on them is a group called a vaccine expert committee that's responsible for evaluating if this should be approved or not. That's not a group of FDA people. That's not government officials. That's not men and women who work for the companies, whether it's Merck, whether it's Moderna. That's men and women like me and you, of course, who may have some expertise in immunology, but they have no stakes whatsoever in the company, or they're not paid by the government. They're a group of experts on this vaccine advisory committee that look at all the data and say it's safe. And that's a group that once they say that, then the FDA can go ahead and approve it for use, et cetera. And so, back to your question, it's a combination of sometimes, Dr. Vanderhoff, people think it was rushed because, it probably happened in a faster timeline than what Louis Pasteur was doing years ago, et cetera. But it's based on technology that's been around for a very, very long time, and we need to appreciate that. And it's based on other experiments and other vaccine candidates that have been in development for a decade plus, and that's how we were able to get here. And so that's the population, really, Dr. Vanderhoff, that I think we got to try to convince the folks who rightfully have legitimate concerns that, hey, I think this is kind of new. I want to wait till it's tested more. And then the last thing I really want to say is, on top of everything else, that was a fair question, January 1, 2021, when these vaccines were rolling offline. But it's important to understand it's been a year now. There are over 9 billion, with a B, doses of coronavirus vaccines given around the world, not just in the US. So, okay, if we were a little hesitant a year ago, but today, on March 10th of 2022, we have given this vaccine and all kinds of versions of this vaccine throughout Canada, throughout the United States, throughout the Caribbean, throughout the West Indies, throughout South America, throughout, you name it, Asia. And again, over 9 billion doses. And I think it's over, Dr. Vanderhoff, I think it's over 4.5 billion doses who received the second shot as well. So it's important to understand that even if you had a legitimate question 2 years ago, you weren't sure about adverse effects, we have billions of people who've received this without these massive numbers of adverse effects. So in short, and it's a long answer to your question, Dr. Vanderhoff, but it's really, one, we got to meet people where they are. We got to share the information as we have it, and on the other side, the folks who are still hesitant do understand that science is a process of collecting information, right? A lot of times people confuse with science is facts. Well, if you remember, if we were around 8,000 years ago, you would think that it was a fact that the world was flat. But with time, we collect more information. We realize, wait a minute, it's a sphere, it's round. And so now we have more information, and we know that, these things are very safe. But in short, meet people where they're at, Dr. Vanderhoff, share the information we know. Those who are hesitant do understand that we have a lot more information today than we had a year ago, than we had 2 years ago. And look at the information. It is available for you to see. It is available for you to evaluate, but feel comfortable that billions of people have received these vaccines and they are safe and effective.
Dr. Berkley, one of the things that you commented on, I think is very true. These are new, and people do, I think, have a sense of caution about new things that they'll put into their bodies. Can you explain a little bit of the science that went into these vaccines, specifically a little bit about what they contain and how they work?
Sure. So to do that, we have to understand what a vaccine is in general and what a vaccine is going to do in general. So the first thing to understand is a vaccine doesn't create anything new in your body. What a vaccine does is exploit something you already have in your body and makes it stronger. So imagine you have a personal trainer. The personal trainer doesn't add different muscles or new limbs or new bones to your body. He or she works with you, and over time, they strengthen your muscles, they make them stronger, they make your bones healthier, your skin feels better. By virtue of going through this training, this education, and in the concept of a physical trainer, it's a physical education, they make you stronger, better, faster, healthier. So a vaccine actually leverages your immune system that we all have. All 7.8 billion people on the planet have this thing called an immune system. There's a small population who may have a genetic mutation, but for the rest of us, almost everyone on the planet has this thing called the immune system, which is your natural body's defense against all kinds of bugs. And if you think about this is really interesting. We eat food every day. You know, we're not cannibals. So we're eating foreign substances every day. We're putting those things in our mouth. Our body is always looking at that, and it's our immune system that's looking at it and making decisions. Is this dangerous? Should I react, or is it not dangerous? So this is happening all the time. In comes a coronavirus, and that infects you. Well, you have an immune response. Your body's going to immune respond to it. But because coronavirus is a new virus in humanity, if you will, our bodies don't have an educated, ancestral, if you will, educated response to it in a strong way. We have a good response, but it's not necessarily a heightened response. And so what the vaccine does is you provide vaccine, and we'll talk about it, Dr. Vanderhoff, the specific bits of the vaccine for coronavirus, but the vaccine takes your immune response that you already have, and like a physical trainer, beefs it up, makes it stronger, so that if you do get exposed to coronavirus by accident somewhere out there, you're going to have a much stronger immune protection and hopefully not get sick at all, or get mildly sick, but certainly not get seriously sick and hospitalized. So that's in general. So it's important to understand the vaccine doesn't create something that you didn't have in you already. It just strengthens something you already have, and that something is your immune reaction. All right. How do you do that? Well, there's all kinds of ways of doing that. In the case of vaccines, they can sometimes use, let's use the measles virus, because again, many of you listeners have received a measles vaccine. In the case of measles vaccine, they have what's called a live attenuated virus, meaning they took measles virus that appears out there in nature and they weakened it. They didn't kill it, but they weakened it. And so they weakened it enough so it's not going to make you seriously sick. And so you take that weakened version of the measles virus and your immune system recognizes it and responds to it. And each time, as Dr. Vanderhoff said, each time there's an immune response, think of your brain and think of how you learned subjects, have you learned your timetables, have you learned your poetry. There is a memory that's attached to your immune response. And that memory, next time you see it, allows you to respond stronger. So in the case of the measles virus, they actually give you the whole virus with all the little bumps on it and the whole circle and all the content inside. They give that to you. You have an immune response. And then if you see measles out there in an environment, you have a really strong response and it squashes it and you don't get sick. Alternatively, you can do what's called killing a virus or killing a pathogen, where they take the bacteria or the virus and they literally kill it. In other words, they make it dead so it cannot replicate. And then they give you that. And that allows your immune system to look at it, respond, generate immune response. Okay, so those are examples of giving you the whole particle, whether it's a whole viral particle or a whole bacterial particle. But another way of doing that is giving you a piece of a particle. So for example, if you've ever tested ice cream at a store, right? You can go to the ice cream shop and you can say, I want chocolate ice cream, and they can give you a whole scoop of ice cream and put it on your cone. Or you can say, hey, I want a taste of it. And they give you a little spoon and you have a little bit of chocolate ice cream. And then you say, okay, that's good. I want to try peaches and cream, or I want to try vanilla. Each time you're getting a taste of it. But even though it's a smaller spoonful, it's a piece of the bigger ice cream, you still can taste it and you can still decide if you like it or not. So instead of using the whole bacteria, a whole virus, vaccine biologists and immunologists might give you a piece of the virus. So instead of giving you, if you look at corona, you remember the corona is a circle with those bumps on it, those glycoproteins, they're very sticky. Instead of giving you the whole virus, they can give you a piece of the virus, and in particular, that glycoprotein, that thing that sticks out, right? Now, you might ask yourself, well, how do they know what piece to give you for an immune response? Here's another important thing. The way the virus enters your body, it's not like a burglar. If you think of a burglar, they will break through a window or break through your back door, and and they violated your property. They went into your home or your apartment, your house or your apartment. Well, a virus doesn't do that. A virus actually has a key. So when we go home to our homes, you don't kick down your door or break through a window. You take a key and you put it in the keyhole, you turn the keyhole, and voila, the door opens. Well, that's how a virus infects us. The virus has a key, and in the case of the virus's key, it's that protein, that glycoprotein, that sticky knob. That's why they call it the corona. That's the virus's key, and that key enters you and finds a cell and binds to a keyhole, if you will. It's called a receptor, and actually that binding of the virus bit and the receptor actually allows the virus to enter your cell. So what the vaccine developers have figured out is if we can block that keyhole interaction, we can prevent the virus from infecting the cell, therefore making the person sick. And so that's how these coronaviruses are developed. Whether they use RNA or other technologies, they are providing a way to block that keyhole interaction. Now, let me say a little more. That glycoprotein, you can actually give what's called purified amounts of that protein, that knobby thing. You can just inject that in you, and that can be a vaccine. Your immune system is going to see that. And as Dr. Vanderhoff said earlier, you'll have B cells with a B, kind of like Berkley. You have B cells that will produce these antibodies that are specific for that knobby protein. And those antibodies will float around in your blood and your plasma and in liquid areas in your body. And if you get exposed to coronavirus out there in nature, those antibodies will block it. And remember, it's like blocking the key in the keyhole. So now the antibodies are binding the virus, and therefore the virus can't get into the keyhole and infect you. So you can give the protein, or you can give a code, a message to produce the protein, right? And a real quick course on biology. All of us are made up of cells. In our cells, we have what's called a nucleus. In the nucleus, we have DNA. The way biology works, plants, animals, you name it, is you go from DNA, which is in all of our cells, to RNA, which, by the way, is in all of our cells. We have billions and billions of molecules of RNA already in our body. And then you go from RNA to protein, right? So when you're developing that vaccine, you can give either the protein itself, which again, remember, if you're thinking of the virus, it's that knobby thing that sticks out, that glycoprotein. You can give the protein, or you can give the message which codes for the protein. And so when you hear about the Moderna vaccine and the Pfizer vaccine, they are giving you the message. That's why you hear the term messenger RNA. And they're giving you that little bit of message, that little bit of RNA, which is genetic material, a little different than DNA, but it's genetic material. And that material has a message to produce the protein. So in short, the vaccine will come in you. The vaccine, again, I want to be clear. I'm talking about Moderna and Pfizer. There's other vaccines which we talk about. But the vaccine comes in you. It's got a little bit of that genetic material, that RNA in you. The RNA goes into your cell. Okay, it cannot enter your genome, but it goes into your cell. And because there's RNA there, your cell reads the RNA, just like you read a chapter in a book with your eyes and you understand the story, you translate the story after reading. Well, your cell reads the RNA and it produces the protein, which is the glycoprotein. And now your cells are producing lots and lots of this coronavirus, little bitty bit of coronavirus glycoprotein, and that's what your immune system reacts to. And your immune system produces a lot of antibodies and some T cells to protect you later if you get exposed to it. So I know it's a long answer, but in short, if you're talking about Moderna and you're talking about Pfizer, it's the RNA bit that codes for the protein, and that protein, remember, is the key in the keyhole, which we want to produce an immune response to that key to protect you from being infected. Now, lastly, there are a lot of other vaccines that are working on all kinds of other technologies, similar to technologies with measles, mumps, tetanus. There's all these different kinds of coronavirus vaccines that are being developed as well. But I just wanted to talk about the ones we currently are using.
Well, thank you so much, Dr. Berkley. And there are many of us who wish that we had had you for our biology courses back in the day. So thank you, very helpful. I'd like to take a moment now to address what has and hasn't changed in our recommendations to schools. As COVID-19 cases and hospitalizations here in Ohio and frankly across the nation have continued to drop, the Ohio Department of Health is easing requirements for case reporting for our K through 12 schools, even as we're updating our systems to monitor COVID-19 community spread. Now, starting today, schools will no longer be required to report positive cases of COVID-19 to their local health department unless the school has actually tested the student and determined a positive result. Now, at the same time, we've communicated with local health departments that this change and the CDC's adoption of COVID-19 community levels do not reflect changes to our quarantine or isolation guidance. Quarantine and isolation measures, as outlined in our mask to stay, test to play protocol for our K through 12 schools, will remain in effect. Mask to stay, test to play supports in-person learning for our students by allowing any student exposed to COVID-19, but who is not symptomatic, not positive, to remain in school while appropriately and consistently wearing a mask. As the COVID-19 pandemic continues to evolve, K through 12 schools should continue to work closely with their local health departments to monitor the spread of the virus in their community. Now, the CDC's community level framework for identifying low, medium, and high-risk counties in our state really does provide a very useful tool for assessing when communities and the schools in those communities should consider escalating or relaxing mitigation measures, including masking. So, to wrap things up, we can all be, I think, very grateful as we look around that the weather is getting warmer. And many respiratory viruses, like COVID-19, do tend to quiet down as we head into the summer. Now, while we're all looking for brighter days ahead, it bears remembering that we've seen lulls with COVID-19 before. If you recall, in each of the past 2 years, the late spring and early summer saw a decrease in cases that was followed by another surge. Now, perhaps this time will prove different, but let's not rely on that. This time, we have more tools than ever to get us prepared for whatever COVID-19 might have waiting for us around the corner, including our vaccinations that Dr. Berkley outline described so well, ongoing public health surveillance tools, which include wastewater testing, and a growing array of therapeutics, treatments for COVID-19. The foundation of our protection, though, remains getting vaccinated. So if you have yet to get vaccinated, or perhaps are due for a booster, this lull in the spread of the virus is a great opportunity to prepare yourself by rolling up your sleeve and getting a shot. So thank you. And with that, Ken, I think we can open up for questions.
Okay, thank you, Dr. Vanderhoff. Our first question today is from Candace Price with WHIO.
Good morning.
Dr. Vanderhoff and Mr. Berkley, thank you so much for doing this today. We appreciate everything that you all have been doing to keep our public informed. So my question, as you just said, Dr. Vanderhoff, we've seen lows in COVID-19 before, and they're usually followed by a surge. And we're also seeing mitigation measures relax a lot right now. So my question, 2 years into this thing, why now? Why are we seeing mitigation measures relax? And why do we feel that that's the right thing to do at this point, rather than maybe months ago or before Delta or after Delta, for example?
Yeah, thank you for that question. It's a great question. And I think it's got many layers. First of all, how we deal with a virus, especially one that is now part of our landscape, part of what we have to live with, is somewhat of a balancing of risks. There are risks to being out and about and interacting with each other. And there are risks to not interacting with each other. There are benefits to wearing a mask, but there can also be downsides to wearing a mask. So the latest guidance that has come to us from the CDC regarding these community levels, I think really does provide us with a nice framework for thinking about how we manage that risk. The reality is that the Omicron surge, which followed right on the heels, of course, of the Delta surge, brought us a really new version of the virus. Omicron looked very different than most of the variants that had come before it. They were all kind of related to each other. Omicron was very different than Delta and Alpha and the so-called native variant. What that meant is Omicron took us a step further towards what we are calling the endemic phase of the illness. So now we're left with something that was much more contagious. It also, though, while it certainly did make people sick, was less inclined to make people sick, seriously ill, than the Delta variant that had preceded it. So now that we're headed into the space of seeing the virus rates decline, it is appropriate for us to keep a close eye and to say, when there's relatively little virus and it is causing very little strain on hospitals, we're in a zone that is the CDC has labeled low risk or green. And that's a situation in which it is reasonable for people to essentially go about their lives. As we see those numbers change and we see more virus and more people ending up in the hospital, our recommendations would shift along with that and say, you know what? There's more virus circulating. It appears to be able to make people sick. And we are going to ask that we re-escalate our protections. One last comment, then I'm going to turn to Dr. Berkley to see what he might add. The other thing that we have to bear in mind is we are in a very different position today in dealing with the future waves of the virus, because we have the benefit of our vaccine immunity. We have increased ability to test, including our wastewater testing, which can be an early warning signal. And now also the growing availability of treatments for therapeutics. And I've described before, it's like a three-legged stool. That's a game changer. But it really does require that we make sure we're taking advantage of all three legs of that stool, including getting our immune systems ready with vaccines, getting tested promptly if we think we might have been exposed or are sick with the virus, and then seeking treatment promptly if in fact we are determined to be sick with the virus. Dr. Berkley, anything that you would add to that?
First of all, Dr. Vanderhoff, that was a fantastic response. So thank you for that clarity. But for Ms. Price and for others, I will add something. And that's, you talked about the Omicron variant, and it was definitely very different. And one of the things we hear all the time by folks who are questioning, should they take the vaccine, or here's why I'm not taking the vaccine, is, oh, well, we saw the data. People were vaccinated. People even had the second dose, were fully vaccinated, and they still got infected by Omicron. Well, so therefore the vaccine's not working. Why am I going to take the vaccine? Well, it's very, very important to understand a few things. One, the vaccines work, and some people who were exposed to Omicron never got infected. So we just have to make sure that we're all on the same page. So everybody who's vaccinated didn't get Omicron. There are people who were vaccinated who never got Omicron, meaning they were protected. They were in the environment where Omicron was, but they did not get infected. But what's really important to understand is even those who did get vaccinated and did get Omicron, what they call a breakthrough infection, they didn't get as sick, and they certainly didn't die nearly with the same frequency. And the best analogy I have for that is this. Police officers today love the fact that they have bulletproof vests or Kevlar vests. Why? The Kevlar vests will not stop you from being shot. And I want to be clear, the vaccine does certainly prevent a lot of people from actually getting infected. But the bulletproof vest won't stop you from being shot. But guess what? If you get shot and you're wearing a bulletproof vest, it might sting a little bit, but you're not going to be seriously hurt, and you're definitely not going to die from a gunshot wound, of course, if it hits you on the vest. And so think of that as the vaccine, that even if you did get infected, much like the bulletproof vest, even if you did get shot out there as a police officer, that vest will protect your life. And so, and as Dr. Vanderhoff said, 'tis the season now that stuff is slowing down. Be comfortable, go get the vaccine, or consider getting the vaccine if you have not done so yet.
Okay, our next question will come from Joe Ingles with the Ohio Public Radio and Television.
Morning.
Good morning. Thank you for this opportunity to talk to you today. I wanted to ask for you to clarify again on these booster shots. Who should be getting them? In particular, I've heard a lot from people who got the J&J shot early on, did not get a second shot, as is now recommended with that, and they're weak because they don't have as much in their system. Should they go get another shot, even if they've had the J&J and a booster? And who should qualify as the group that is, what are we saying? At risk, highest at risk, that qualifies for another booster. Can you clarify all that for us, please?
Yeah, I'd be happy to. And here's what I'd say. I think it's helpful to think about this in as simple a terms as we can, because otherwise it's relatively easy to sort of get lost in the complexity of the dosing, et cetera. Here's the bottom line. What we now know is that the vaccine series begins with those first 2 doses, and there's some differences between ages and how much time ought to be between dose 1 and dose 2, but that's what we would consider the initial vaccine series. It sets the table, it creates the foundation. Now, for most people, there does appear to be a real benefit to getting then that a third booster dose, assuming then that they don't have problems with their immune systems, because people who do, their first series actually is 3 doses followed by a booster. But regardless, there appears to be real benefits to that booster, because what the booster does is it takes an immune system that's primed and ready to go, has some ability to fight the virus, and it basically shores it up and gives it even stronger memory and even more complex memory regarding the virus and how to deal with the virus if it bumps into it again in the future. Now, who's going to benefit from that? Well, boosters now have been approved or recommended broadly for people who got those initial doses, particularly those who are young adults and above. But the benefit really becomes even greater as we age and if we have underlying health issues. And those health issues, by the way, can be some pretty common things like high blood pressure or being overweight or having diabetes. All those things count towards increasing your risk. So while I'd like to see everyone who got their primary series consider going out and getting boosted, including young people, it's especially important as we get older. And so people who are over the age of 50, I think should really give serious consideration to getting that booster, and certainly people over the age of 65. Again, let me turn to Dr. Berkley. Dr. Berkley, what might you add to that?
Again, you nailed it. I'll just add, there's no downside for anybody taking the booster. I mean, it'll help. It will help. To your point, once your immune system has been primed, whether you're young, middle-aged, or older, getting that booster will just make your immune reaction, your immune response that much stronger. So getting a booster in general is a great thing to do, but especially if you're at risk, just like we do in regular life. When we're at risk, if we're older or have, pains in our legs, we take more caution and time going downstairs, right? So if it's kind of a general sense of how we work as human beings. The more someone is at risk at something, the more sensitivity we place on us, and the more we try to protect their situation. And so that's the same philosophy of the booster. The booster is good for anyone who's had the first 2 shots, but if you are at risk, it's that much more beneficial for you, and you should consider taking it.
Can I follow that up, please?
Yeah, okay, go ahead. Yeah, because there was another part to your question I didn't get to.
Yeah, the part that I wanted that you didn't get to, and you might have started to answer it, is about the J&J. If someone only got one J&J and they have a booster, they need another booster, what do? There's conflicting information all over about that.
Yeah. So the simplest thing I would say is this: generally speaking, what we would recommend for people getting boosters is to get one of the mRNA boosters. So if you got J&J, at least 2 months after you got your J&J shot, which now for most people, they are past that 2-month mark, I'd recommend that you consider going out and getting a booster with either Pfizer or Moderna. If you're someone who's over the age of 18 and want to get a booster, you can get either Pfizer or Moderna. Currently, if you're in that 12 to 17-year-old age bracket and want to get a booster, right now that would be a Pfizer booster because that's what's FDA approved at the current time. But my expectation is that I would expect that as more data rolls in, it's very likely that at some future date, we would see Moderna included in that as well. They're kind of cousin vaccines in terms of how they work.
Yeah, and I'll just add, Joe, I really, really appreciate your question, because your question really speaks to one of the underlying things that we've experienced over the last years, which is, oh my goodness, just conflicting information coming out from the experts. And so thank you for highlighting that. And it's so important that we all understand, and I want to be clear here, not just the lay community, but scientists who have expertise in vaccines, scientists and physicians who have expertise in healthcare and how to deal with diseases. We have to understand that this is all happening in real time. It's happening now. We are getting the data now. Every day we get more bits of information, and that additional data we get helps us to further clarify, to your point, some of what seemed conflicting or was thought to be conflicting. And Dr. Vanderhoff said just now that as we get more data, we're going to better know. And I just want all of us to remember that the scientific community, the medical community isn't hiding data and trying to try to hoodwink the public. It's that each time we get new bits of data that gets us further or closer to, oh, that's exactly how, in this case, coronavirus is working, and so we should tweak it. So thank you for your question. It's so important. But as we get more data, saying it differently, 3-5 years from now, all these questions will have 100% clarity, hopefully, on how we move forward. But thank you, Joe, for that question.
Our next question comes from Pete Grieve with Spectrum News.
Hello, I'm wondering if Ohio, from its, the genomic sequencing that happens in the state, if we're still seeing all Omicron more or less, if we're seeing any of the subvariant that's talked about a lot, or if we're seeing any other variants.
Yeah, thanks. Another great question. One of the things I'd encourage folks to do is feel free to go to our website, coronavirus.ohio.gov You can look at a lot of the information that I'm about to communicate there. And we do work to keep it as up to date as possible. Remember, the genomic sequencing that we do does run, just for reasons I've outlined previously, does run a little behind due to what's involved with gathering adequate amounts of that data and running an adequate number of samples through the very complex analysis that is genomic sequencing. Having said that, what you'll see is that the vast majority of the cases that we're seeing in the recent weeks have in fact been Omicron. It's almost exclusively Omicron, and within Omicron, the BA1, which we'll call that, kind of the form of Omicron that first hit us and that we've been most used to running into, is the lion's share of that, well more than 90% of the sequences, and a small percentage of the remaining sequences have been BA2, which is the other form of Omicron that's seen all over the world. So we see both BA1 and BA2 here in Ohio, by far mostly BA1. And we're not seeing a change in the BA2 to BA1 proportion, nor would I expect that we're going to see much of a shift there. They're really two subvariants within a family, and no reason to really expect that change.
Just a note here, since we started about 11:10, we're going to go an hour until 12:10. Our next question comes from Titus Wu with the Columbus Dispatch.
Hi, Doctor. My question is, so with kind of the shift to, weekly reporting of COVID-19 data, not daily, I guess what I want to ask is, one, is this a sign that, would you say that Ohio is kind of out of this kind of COVID-19 situation, COVID-19 pandemic? And two, I guess for someone who like some Ohioan who likes to keep track of kind of the COVID-19 situation here in Ohio, is it going to be a bit more difficult trying to, I guess, really actually understand kind of the virus's situation here in the state if, now that it's only being reported weekly? Like what kind of differences or what kind of more difficulties would it be in terms of trying to just understand one's own safety here in the state?
Yeah, that's a terrific question. And the first thing I want to say is that this is not, I would not anticipate that this is in any way, shape, or form going to reduce our ability to keep a close eye on the virus or its activity. Actually, what it is a reflection of how not only we in Ohio, but the entire nation is looking at how the virus is behaving and impacting our communities. I used, again, the example of comparing the flu to a cold in my earlier comments. I think it's a pretty easy to understand analogy in that what we've come to learn, especially with Omicron, remember, Omicron has caused a real shift in this virus and moved it much more in the direction of what we would expect of an endemic virus or one that we live with. And that is that what's important is how the virus is impacting us in terms of severity, how many people it's causing to get really sick and therefore land in the hospital, in the context of how much of it is out there. And so if we're looking at just one of those measures, how much of it's out there, we're missing the full picture, because as I shared in the example of a cold, many of which, by the way, are coronaviruses, a cold that's really not making people very sick, but there's a lot of it, and a flu that might have a lot less of it out there, but it's making a lot of people sick, we'd be more worried about the flu. Same's true with this. What has come to be evident is that doesn't change much faster than roughly weekly measure. and that it's more accurate, it's more effective, because all we're doing is, with our testing at any point is sampling. What is most important is what's that week average of those numbers and those figures. That gives us the snapshot that is probably the shortest window of time that is useful. And the reality is that actually for quite a long while now, even during the Delta surge, really what health experts were looking at is what's been going on over the week, not what's going on in any given day. In fact, you've probably heard me comment about the fact that there are certain days of the week where we know the testing goes up and certain days of the week where testing goes down. And so we haven't really relied on a given day's data. We've looked at the week because there are just patterns to how the week works. So wonderful question. No, I don't think this is going to in any way reduce our ability to monitor this. Frankly, I think as Dr. Berkley had shared, as we have grown to understand the virus more, as our learning has improved, so has our understanding how best to monitor the virus's behavior. Dr. Berkley, anything that you'd want to comment?
Absolutely not. That was perfect.
All right, our final question today comes from Laura Hancock with Cleveland.com, the Plain Dealer.
Hi, Dr. Vanderhoff. You've talked a little bit about endemic. And so I was just wondering for people, if you could explain sort of like what's the difference between a pandemic and an endemic? Thank you.
Yeah, I think the simplest way to think about it is this. When we're talking about an endemic illness, we're talking about something that is part of our landscape. It's something that we as a population have to live with. Think about things like colds, think about things like the flu, think about things like RSV. These are all respiratory illnesses that are endemic. Now, we take some of them very seriously, right? We take flu, particularly in a bad flu year, very seriously. We take RSV, which we know can have such a terrible impact on our children, very seriously. And by the same token, we are taking COVID-19 very seriously. And we'll continue to watch it very closely and take steps to deal with it if it resurges, which I think it probably will. But that's an endemic. When we're dealing with a pandemic, what we're really talking about is an illness that is new on the scene. It's causing a lot of illness to a lot of people all at once. And our tools and ability to deal with it are extremely limited. That's changing because A, the virus is changing. As I've explained, Omicron has changed, and our ability to deal with it and to monitor it is so much better today than it was at the start when it was an entirely new virus we were facing. As I've said before, we have vaccinations that are highly effective and incredibly safe. We have a lot of testing, including now wastewater testing, which gives us an early warning tool. And then, of course, we have an emerging, growing body of therapies or treatments, which we did not have at the start of the pandemic phase of this. So that's really the difference between a pandemic and something endemic. Dr. Berkley, thoughts?
Sure. Another great question. Thank you very much, Laura. The only thing I'll add is two things. One, when you think about humanity and all the diseases we have, in all our time, however long you think we've lived on the planet, we've only really gotten rid of two bad bugs, polio and smallpox. So think about that. We've been living with malaria, tuberculosis, hepatitis, influenza, measles, mumps, rubella, et cetera. So just all these diseases that are there. And so to Dr. Vanderhoff's point, those are endemic. They're here, we live with them. And as he perfectly mentioned, pandemics and epidemics, these are new outbursts. But it's also important to understand that sometimes things that are endemic can lead to flare-ups or, for example, measles, right? You hear every now and then there's a measles outbreak in New York or California or somewhere else in the world. And so that's an outbreak, but it's not a new epidemic or a new pandemic. It's an outbreak. Then eventually we get it under control and it gets back to endemic level. But as Dr. Vanderhoff said, endemic is something that's here. And as we think of, oh my gosh, the coronavirus, what's happening there, realistically, folks, we are not, or let me be optimistic, we are probably not ever going to get rid of it, or at least get rid of it from the planet anytime soon. But the key is to get it under control so that it's at endemic levels, meaning it's there, just like measles is there, just like tetanus is there, but we have it under control. And the way to get it under control is twofold: to prevent people from getting it and prevent people from spreading it. Both of those things are done one of two ways: either human beings are removed from the planet, or we vaccinate to protect ourselves, or get protective immunity elsewhere. So that's all I'll add, Dr. Vanderhoff.
We want to thank all of our guests today. Dr. Vanderhoff, do you have any closing remarks?
I just want to thank people again, encouraged by what we're seeing around the state, encouraged that we continue to see people seeking vaccines, and we would really just want to remind everyone of how important it is to be prepared for what might be around the corner. It's I think a good and appropriate thing for us to rejoice as we see things getting better and the weather improving. But let's use this time in a smart way. And if you're not vaccinated, please think about getting vaccinated. And if you're due for a booster, please think about getting a booster. Talk to your provider about whether that's a good choice for you. And again, I want to thank Dr. Berkley. Wonderful to have him on board with us today, and really enjoyed his explanations and examples. And thank all of you for your continued attention to this important issue.
This concludes today's press conference. Thank you again for joining us.